Welcome back to PedsCrit. I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
Yes. And we are here today. This is part 2 of our VA ECMO and septic shock series with Dr. Abhinav Totapally, a pediatric intensivist at Nicklaus Children's Hospital in Miami, and Dr. Brian Bridges, the PICU division chief at the Medical University of South Carolina in Charleston. We're referencing with them today a paper that they published together in January of 2025 in PCCM titled Central or Peripheral VA ECMO for Pediatric Sepsis, an outcomes comparison in the ELSO dataset from 2020 to 2021. So, Brian and Abhinav, what are the key considerations in choosing a cannulation strategy for VA ECMO in children with septic shock?
Sure. The paper was about central versus peripheral cannulation. Obviously, central involves a sternotomy and often involves draining the RA and then returning into the ascending aorta. The advantages of that include the fact that you generally have higher flows. You generate higher flows with good drainage. Good drainage is paramount in any ECMO, but especially in septic shock. I think that's what a lot of the initial papers from Graham McLaren kind of advocated is high flow with central cannulation. The disadvantage is that I think it's the familiarity for a lot of units is going to be not there, depending on whether you have a cardiothoracic surgeon in-house or a CT surgeon or CICU program. And then I think there is concern about like the bleeding risk in these patients, as well as the risk of nosocomial infections. The alternative is peripheral cannulation, which can be done either all in the neck, all in the femoral or in the groin, or a combination of neck and femoral. The benefits of that is that that's what most centers are used to, especially in the pediatric world. PICU, especially, are general surgeons. Depending on the unit comfortability, it may be faster than doing a sternotomy. The disadvantage potentially is you may flow a little bit lower depending on what size cannula you put in and the size of the vessels, but I think that is variable. One of the concerns when you cannulate the carotid in the neck is the risk for a stroke or CNS infarction. And then, of course, the concern with cannulating the groin is your Harlequin syndrome, your north-south syndrome, essentially, that you have this differential hypoxia between the lower part of the body and the upper part of the body. The paper was essentially assessing in a very broad way between central and peripheral, but we didn't actually delineate between neck cannulation versus groin cannulation.
We talked about how we're putting more complicated patients on ECMO and supporting them. I think cannulation's gotten a lot more complicated as well. My first ECMO patient was in the PICU at Emory. Gosh, I think I was an intern, and for some reason they thought I was a weirdo. I did an elective as an intern in the PICU, and they couldn't figure out why I was there. So that's 20 years ago. I saw this cannulation, refractory shock from calcium channel blocker ingestion, right, in a teenager, right? The pediatric surgeons cannulated the teenager through the neck, right IJ, carotid. And really, that's all that was offered, right? At any time for any patient in the children's hospital, they were good at it. But, that was all that was offered. And literally, there was no adult ECMO in the city or the state at that time. So things have changed a lot. So now, patient in the children's hospital, you may cannulate through the neck. Or if it's a teenager, at my current hospital, the cardiac cath docs in the adult hospital may offer VA ECMO through the FEMS, femoral artery, femoral vein with a reperfusion catheter in the leg with the femoral artery catheter, right? And that's percutaneous. And then the consideration for a patient with refractory septic shock, whether they be a little patient or a big patient, essentially cannulating for higher flows and better outcome. We don't have less choices, and sometimes that's actually tougher. Who does it, and where will they put the cannulas?
Yeah. That's been a huge learning point for me as I change institutions and sort of wrap my head around the other ECMO programs is it could be a general surgeon or a cardiac surgeon. It could be a cut down with modified Seldinger, a cut down with a graft. It could be percutaneous. I guess to come back to your point about carotid versus femoral artery, can you explain why someone would be more likely to use the carotid artery maybe in a 4-month-old than a 40-year-old and what the sort of general landscape
14-year-old.
is? Or a 14-year-old, yeah.
It's all about vessel size and the vessel anatomy, right? I think that's what it comes down to. And I'm not a surgeon. I don't put the cannulas in myself. So I will say that. I think the cannulating in the IJ is going to give you the best drainage, and then the cannulating in the carotid is going to give you the best place to return. The femoral vessels, especially in a 4-month-old, are just so small. It's probably going to be a much more challenging cannulation, like time. And remember, time is of paramount importance when you're cannulating. And then, of course, if you sacrifice by putting smaller cannulas in, that's obviously going to raise your overall resistance of your circuit, right? So from a drainage and return standpoint. And so you're going to be a little bit limited on the actual delivery of what you're going to be able to do. And then as you get older, especially like a teenager, the femoral vessels get a lot bigger and you are able to sustain good ECMO drainage and return with that. And I think sometimes people do like a combination, right? In my new institution, it's like in a toddler age group or like kind of the young 5-6 years age group, like sometimes draining from the neck and then returning from the groin as well.
How much flow do you need? And then there's obviously little babies are always tougher for cannulation. I think the good rule of thumb that was passed down to me, I'm going to give Heidi Dalton credit for this rule, for femoral cannulation, a 15 kilo rule. I think really what that means is for drainage, right? If your patient is less than 15 kilos, especially if they are going to need a fair amount of flow, like in a sepsis patient, it's going to be tough to get a femoral venous cannula that you're going to get enough flow out of, right, to feed your ECMO pump. Now, what I find really interesting is that this may not be true for return. This is a valuable lesson, I think, from the VV ECMO world where a few years ago, we lost our double lumen VV catheters, and a really enterprising group in London, a PICU, started draining the right IJ and returning to the FIM on VV ECMO. And these were small return catheters, but again, this is for VV ECMO. And even these little baby FIMs were enough to return on VV. Now, for sepsis, obviously you need a lot of flow. And those femoral veins are not going to be enough for at least drainage, right? But above 15 kilos, and especially when you get to your teenagers, I've seen really skilled cardiac cath doctors femorally cannulate and get 6 liters per minute plus of flow. Really impressive flows. And I've got a big bias. I don't let a cardiac cath doctor or surgeon do VA femoral ECMO if they're not willing to do a reperfusion catheter in the leg that is being used for the femoral artery cannula. There are centers who push that and say we don't do it for every patient. In my opinion, that's a standard of care. If you're going to put a big cannula in the femoral artery, you better reperfuse that leg because you might lose it. Unfortunately, sometimes you lose the leg even if you reperfuse the leg, right? Dr. Bartlett at an ELSO meeting, he stated we used to cannulate everyone through the neck, and unfortunately we got strokes. Now we're cannulating patients in the FIMS, and sometimes they lose their leg. Those are the risk and the morbidities of those cannulation strategies. The Boston Children's Group had a great paper a number of years ago that showed a reduction in stroke in children that got central cannulation versus peripheral cannulation through the neck. That didn't pan out in Abhinav's paper. We didn't see a big stroke difference between the two cannulation strategies, but most of us have seen patients cannulated through the neck for VA who have suffered a stroke. Unfortunately, that is a real risk when you have a sick patient and you cannulate that carotid artery.
I want to ask a question about how we deliver care to these patients through an open chest central cannulation. So, our core hypothesis is these patients need oxygen delivery. And, with that hypothesis, the best way to get that great flow is to cannulate the big vessels. Even the RA and the aorta can't get any bigger, right? But when I think about that in my current institution, we've great PICU here. I don't think any of our nurses in the general PICU know how to take care of a patient with an open chest. And then when I reflect on who takes care of septic shock, well, it's probably the PICU. So logistically, am I going to need to now transfer this patient to our cardiac ICU for the open chest, or do we need them in the PICU for their septic shock management? How do institutions tackle questions like this?
That's a great question. And it's one of the $1 million questions, I think, of this topic. Full disclaimer, I've never actually cannulated anyone centrally for septic shock, right? Because we didn't do it at Vanderbilt either. And we don't do it at my institution either. I think the first thing is, if you are going to do it, I think you have to figure out, these are some of the questions you have to answer, right? And I think in some centers, they do take them to the cardiac ICU and then they manage them. But I think these are some of the logistical barriers to cannulating centrally, right? Having a cardiothoracic surgeon that's willing to do it, And then having the staff trained up to be able to manage an open chest, right? And all the possible complications associated with that. Is there a world where you can train PICU nurses to do this? Of course, yeah, I think so. There is. But that takes investment, right, to do that. Why I understand why places move their children up to the cardiac ICU to have these things done. One thing I will say is that as much as we talk about central cannulation, out of the 1,200 patients in our paper over 20 years, about 112 of them were cannulated centrally, right? It really isn't a lot. Expertise is not that common. If we're going to manage them in the PICU, can we train up our staff to take care of an open chest? Who's going to be cannulating centrally? Where is that cannulation going to happen, right? You have to answer those questions first before you pursue the program. I don't know if one is better than the other, but I do think that the training and the thoughtfulness is required.
Those are great questions. And if it makes you feel any better, these are questions that I'm asking myself in my relatively new position. I'm at another PICU. I've been here less than a year. And when I was working with Abhinav at Vanderbilt, we were asking these questions about cannulation site. And I believed fully that if we put in big enough cannulas and provided high enough flow peripherally, that we could support these patients because we had done it, right? We were literally standing in front of a patient that we had peripherally cannulated. We put in the biggest cannulas we could because it was a teenager with refractory septic shock. We provided multiple organ support, continuous kidney replacement therapy, therapeutic plasma exchange for TAMOF, and we had good outcomes. So I'm like, if we do peripheral ECMO well enough with high enough flow, it should work. So we did the paper, and really the data doesn't support that. If you look at this in as retrospective, it's limited in that respect. But patients that got centrally cannulated clearly had a higher survival to hospital discharge. And it's buried in the supplement, but I think it's actually really important. If you just take all comers of peripheral versus central cannulation at 4 and 24 hours, which is what ELSO gives you as far as flow data, you're around 30 mLs per kilo per minute higher of flow in the central versus the peripheral. And I actually presented my division here in Charleston this paper. We did a journal club, and I says, well, I think this is important. Will you listen to me talk about this? I invited the surgeons. If I'm going to make a data-driven practice change, you got to get the surgeons invested. And maybe most importantly, the ECMO team. Had some surgical participation. I really wanted all the cardiac surgeons, obviously, if we're going to talk about this. And then one of our great ECMO specialists, lead ECMO specialist, was really excited about it. The two cardiac surgeons who weren't there because they were busy in the OR, she saw later that day and she goes, hey, we just reviewed this paper. Would you cannulate a kid with really bad sepsis centrally if we needed it? And the head of cardiac surgery here goes, yeah. And then his partner, who formerly practiced in Italy, goes, oh, I've done that. We used to do that in my old hospital in Italy. The point of doing this clinical research and asking these questions, it's really good to be right. It makes you feel better. But if you're wrong and your strategy probably isn't the right strategy, let the data change your practice. So I, as the relatively new guy, is saying, hey, we have this data. Maybe we should do something different here. And the same question comes up. Okay, the cardiac surgeon cannulates the teenager in the PICU. The PICU is really good at sepsis management and kidney replacement therapy and TAMOF. But now they've got cannulas in the middle of their chest. Should we leave them in the PICU? Will the bedside nurses be comfortable with central cannulation? The ECMO specialists are comfortable. They're going to take care of those patients anywhere. But are the bedside nurses? Should we move this patient who's centrally cannulated? We do it all the time, right? But should we? As this data comes out and as we ask ourselves these questions, I think at least we're all asking the same question. And it's still an evolution for me in my new position in my new hospital.
Oh, absolutely. I imagine that these practice-changing conversations, there might be a little bit less resistance if it's a cardiac surgeon cannulating everyone already, or if it's a mixed unit and your cardiac surgeon is comfortable with that unit. Can you describe the landscape at MUSC for us?
Sure. Again, as the new guy, what comforts me is it's a collegial group, right? And maybe because we're not the biggest children's hospital in the country, but we are still the children's hospital, really referral center for the state and the surrounding area. I, as a native of South Carolina, take a lot of pride of that, to come back home after being away for 20 years. And we work closely together all the time. We take care of cardiac patients in the PICU, and the cardiologists and cardiac surgeons come to the PICU, even though they've got this beautiful separate cardiac ICU. I'll give them a plug, number 2 cardiac program in the country with the number 1 outcomes in the country.
Wow, congratulations. I'm glad you shared that.
They do a really good job. They do a good job of realizing that their services are needed in the NICU and the PICU and all over the children's hospital. So I think I'm fortunate to be in a place where those discussions can happen. When you're a PICU doctor, you've got to work well with others at all times, because you're going to be working with a lot of surgeons and subspecialists, and you got to do what you got to do to take care of the patient.
Wonderful. What a great example of just the collaborative multidisciplinary care that our really critically ill patients require.
So we've talked about sort of the struggles of changing any ECMO program, including and especially adding open chest central cannulation to the PICU. Let's get into some of the nitty-gritty of managing a patient on VA ECMO for septic shock. Starting with LA hypertension and the decision to sort of decompress the left atrium. What's your clinical experience there?
Yeah, it's a great question. I think the key for ECMO is resting your heart and lungs, or especially the heart. Part of resting the heart is also not accruing more injury. Persistent elevation of your left atrial pressure, your end diastolic pressures, is going to lead to continued myocardial injury, and then specifically in the case of elevated left atrial pressures is going to start leading to pulmonary edema and cause lung injury. And so that is a paramount of consideration when you're on VA ECMO. The first thing you want to evaluate is, do you have pulsatility? You often have an arterial line, right? Is your LV able to eject natively? And remember, when you're putting high flow in the aorta, it is a lot of afterload to the LV. So you have to ensure that you have an aortic valve that's opening and pulsatility. If you're ejecting, I think that's good because that is a native way to decompress the heart. Now, in the scenario where you're not ejecting, or you're ejecting not as well, and you can see on the echo your aortic valve isn't opening, I think then you have to talk about some more other interventions to decompress, right? So the adult world and teenagers, you have an option to do an Impella when you cannulate, right? Which is a great way to decompress the heart and then as a bridge to come off ECMO. If you're centrally cannulating, you can put an LA vent. But then if you're peripherally cannulating and the kid's a little younger, what do you do, right? And I think that's when you have to talk to your interventionalists about doing an atrial septostomy to make a connection between your left atrium and your right to decompress the left side. The reason you're doing this is so that your left side heals and that you don't have backflow into the lungs and causing pulmonary edema. So those are all things that you have to think about and ask. And depending on your institution and the patient, you may have different options available to you. But assessing for that and managing it is super important.
It is tricky with these sepsis patients because we just talked about how important it is to flow high to make sure you're getting end organ delivery of oxygen. But if I flow high, I'll be taking away preload and adding afterload, right? So whenever I have one of these patients, especially the patients with poor cardiac output that goes on VA ECMO, I'm always worried about LA hypertension and the need to decompress the left heart. And I think what I teach my fellows is that I especially worry about it when my pulse pressure is less than 15. If your pulse pressure is less than 15, there's a good chance your aortic valve is not opening. Unfortunately, all these kids that go on VA ECMO with refractory sepsis already have bad lungs. So are their lungs bad because they have multiple organ dysfunction? Is it bad because they have bad LA hypertension and it's backing up into the lungs, right? That pressure. It's hard to tell. I'm a big fan of decompressing early, again, to mitigate the backflow and injury to the lungs, and especially to mitigate the injury to the LV, right? A distended left heart that can become ischemic if the left-sided pressures are too high for too long.
Another common scenario in patients who are femorally cannulated is the development of this north-south or Harlequin syndrome. And in your mind's eye, you can think about a patient with some intact cardiac function that's ejecting perhaps even poorly oxygenated blood into the proximal aorta, but you have that ECMO cannula in the femoral artery pushing up richly oxygenated blood, and there might be a mixing cloud somewhere in the aorta, so to speak. How do you go about detecting that? And if you detect it, is that significant? And what might you do to help mitigate some of that?
It was a great question, especially if you're cannulating femorally. I recognize that is something you have to watch out for. So sometimes just putting pulse oximeters on your lower extremity and right arm, and then seeing if there's a difference between the two. Then you have to ask yourself, how clinically significant is this, right? How much of that is this mixing and what this oxygen level is getting to the brain, right? That's like the biggest thing you want to think about. Sometimes like cerebral near responders can be helpful from a monitoring standpoint as well to kind of aid in that. And I know there's a lot of active research in that area. But I think that's in terms of like how much you intervene on, that's really what I would base it off of, is what is the brain seeing? And is that enough for the brain to be seeing it? You could overcome some degree of hypoxemia with good cardiac output, right? That would be my caveat to that. But I think you do have to consider how much is the desaturation they're seeing.
Yeah. Patients who are femorally cannulated, it's interesting that as you support them and their left heart recovers, and it can compete with the return of highly oxygenated blood that is being returned via the femoral artery. And it can be dramatic where you really have an upper blue half and a lower pink half. And that's, to me, easy, right? That if you see that sort of differential oxygenation, probably the simplest way to do that is actually to convert to VVA. And what that means is to split the return blood between your femoral artery and a venous cannula in your right IJ, right? So you can get oxygenated blood to the right heart and thus to the pulmonary circulation. What I will tell you people sometimes get tripped up on is not differential hypoxia, but another phenomenon which is actually good. So you have your patient with poor cardiac output, bad lungs, femorally cannulated or cannulated anywhere really for VA. And what happens as their cardiac output starts to improve, but their lungs aren't quite good yet, their SATs and their PaO2 actually fall, right? Because if you've taken care of anyone with really bad cardiac output on VA ECMO, their PaO2 is really high. It looks just like post-ox ECMO blood, right? But as their cardiac output improves, and especially with imperfect lung, that PaO2 falls, the SATs will sometimes fall. And that's actually a good sign of recovering cardiac output. And that's not differential hypoxia. Much like my patient with ARDS, I don't need a perfect PaO2 for a VA ECMO patient in that scenario. I don't need a perfect SAT. So I don't sweat it when my patient who has poor cardiac output and has a PaO2 of 300, their pulsatility returns, their mixed venous SAT improves, their lactate clears, right? And their SATs have gone from higher to like 88. I would tell my fellow, hey, your patient's cardiac output is recovering, right? That's not differential hypoxia. That's recovery of cardiac output, right? And yeah, I agree with differential hypoxia. Probably an easy way is to put a pulse ox on the ear, put a pulse ox on the toe. You can use NIRS. Those are two different situations, right? One I can tolerate with improved lactate, mixed venous SAT, and patient condition. One I can't because I'm not getting oxygenated blood to my brain.
Oh, really important clinical pearls here, and we appreciate it. Something that happens, especially if you've cannulated a patient for sepsis and they do die, is a really tough inward look at both everyone's individual management and sometimes of the program. Oh, if we could do this, oh, if we could do that, maybe we would have been able to save the patient. What outcomes should we expect from using VA ECMO in children with refractory septic shock?
Well, going back to what Dr. Berger said at the beginning, this used to be a contraindication for ECMO. So we've come a long way since then. Generally, mortality has been around between 55 to maybe as high as 70%, depending on which studies you look at. Our overall mortality in our study was 55%, which is 20 years of ELSO data. For something that was considered a contraindication, actually we've come a long way from that. The mortality is still high. I do point again towards the fact that a third of our patients are rested beforehand. there is a discussion about deploying it earlier. Would our outcomes be better? And I don't know the answer to that question, but I do wonder about that myself. And I think the one thing our study probably didn't touch on is the morbidity afterwards, right? Which is the degree of long-term end organ dysfunction, specifically related to AKI. About half our patients need renal replacement therapy, which can be for a whole host of reasons. But there's a lot of evidence that just because you need renal replacement therapy does not mean that you need long-term dialysis. But does the AKI and renal failure that you accrue from septic shock, what does that mean for these patients long-term, right? And so I think those things have to be investigated a little bit further. 55% mortality, I mean, just to give that comparison, for neonatal cardiac, I think that the outcomes are about similar. If you just look at overall survival, it's about 55 to 58%. So this isn't too far out of the realm of some of our other cardiac reasons for going on VA ECMO.
Anytime a patient needs to go on ECMO, their predicted mortality is pretty high. We have a few rare exceptions, right? Like maybe if you're a big ECMO program, you'll put on 1 or 2 meconium aspirations a year. Maybe you'll put on a status asthmaticus on VV. Most of our diagnoses, including for our bad refractory septic shock, looking at a survival to hospital discharge around 50%. I do think it's worthwhile reminding your team that it's a very sick patient. There's no other modality to go to. This is the end of the line. This is the bottom of the algorithm for refractory pediatric septic shock. This is a good time for having multiple teams involved. I'm very much in favor of having palliative care follow all of our ECMO patients in a children's hospital, right? For the support of the bedside providers, for the family, I think it's always wise to remind the family of how sick the patient is. And I try to be very upfront with, we can provide this support. About half of the patients who need this support don't make it home. I think you have to set up the expectation, and you hope that things work out well for the patient. But I think whether it be the family, the bedside nurse, your fellow, your partners, the ECMO team, it's best to be realistic about those numbers and to talk about it openly.
I will say it's been such a pleasure speaking with both of you today. This conversation's really had it all. Sepsis and septic shock is probably the core diagnosis that we take care of in the pediatric ICU. And ECMO is that modality that we all get really excited about. And there's so much to learn. There's so much that we've learned in the recent years, so much to come. As I reflect on our conversation today, some lessons learned are that in our patients with septic shock, who we were thinking about cannulating to via ECMO, we need to reduce and limit irreversible organ injury before, and especially cardiac arrest. And we need to try to achieve high flows, especially really early on, to meet that oxygen demand for all their tissues. And we watch our typical and maybe even a bit more sophisticated markers of oxygen delivery to ensure we're delivering the oxygen well. And then these patients need collaborative multidisciplinary care, from the surgeons, the intensivists, all the way through the palliative care doctors and all the other specialists and subspecialists that will need to take care of these kids. Of course, nursing care and ECMO specialists go without saying. As we think about where the literature stands today and we look forward, what do you see as some questions unanswered? What do we need to know next?
So I think part we haven't really talked about is like the antibiotics on ECMO, right? Because I think that's like the other part of all of this. At the end of the day, that is actually the treatment, because the volume distribution changes on an ECMO circuit and your dosing of antibiotics often is different. And so thinking about that and investigating that further is the other part of all of this. Maybe the most important part, actually. And I think the last thing I would say is sepsis has so many different phenotypes, and that's not something that we can capture in a big retrospective study like this, right? And I think there is some granularity that we have to kind of investigate about like the different types of patients, right? Not just like cold and warm shock, but I think there's like many more phenotypes just outside of that. And so I do think that investigating that is another part of all of this.
I think we're just starting at the beginning of this. Again, now that we are supporting more pediatric patients with refractory sepsis with ECMO, now I hope Abhinav and his paper sort of sparked a discussion about cannulation sites and, the collaboration between the PICU and cardiac surgery. So I think we're just at the beginning of this journey of supporting these patients, providing multi-organ support and cannulation strategies. I think we've come a long way in a short period of time, and I think Abhinav's paper will stoke a lot of those discussions here on out.
Oh, wonderful. Well, we appreciate you two joining us today so much. Is there anything you'd like to share or recommend that the listeners check out before we wrap up?
If people want to read more about this topic, I think Graham McLaren's initial papers are really great resources. And then some of the stuff out of Australia and New Zealand in general, they have a bunch of different articles that have come out on this topic that we reference in our paper. And I think it's like the cornerstone of a lot of the reason why we do these things. And so I will also point out to Graham McLaren's editorial of our paper is also a very good resource, I think, as well. Those are kind of a few things.
Yeah, I've learned a lot from Abhinav's paper. Graham McLaren, I've gotten the pleasure of speaking with a few times about these topics. And the point of his editorial is central cannulation for every pediatric sepsis patient is not actually the answer. It is for some. Even he admits he's a remarkable guy who I would recommend his papers on ECMO support and refractory septic shock. He is an adult and pediatric intensivist who has worked in Australia and now works in Singapore. And he's admitted as much as that where he cannulates and how he cannulates really depends on the resources he has around him and the surgeons he has around him, right? That's just like all of our PICUs all around the country and beyond, right? All of us have different resources, patient populations, and surgical capabilities. Also, I'll put a plug in, I think you'll hear vigorous debate about these subjects. The ELSO meeting that's held every year, and if you're listening internationally, there are great ELSO meetings both in Europe and Asia and around the world. So if you ever get a chance to attend, it's a great meeting. You can meet some incredible people and learn a whole lot.
Wonderful. Can't think of a better way to close this out. Dr. Abhinav Totapally and Dr. Brian Bridges, thank you for sharing your expertise with us today.
Thanks for having us. It was great.
Yeah, thanks.